First, we will discuss the endotracheal intubation, and we will proceed through this chapter. First, as Ghaida discussed, the indications for the insertion of endotracheal tube and how it is inserted, we will complete with the lecture. Okay. First, how deeply should the endotracheal tube inserted in the trachea? We have two methods for the determination of the depth that the endotracheal tube should be determined. First, the nasal septum target length. The nasal septum target length, as we see in this picture, we measure the distance between the nasal septum and the air loop or the targus. This distance should be the depth of endotracheal tube plus 1 centimeter. This is the first method. Also, as we said, we can use it before or after the insertion to adjust the depth. The second method, it will be according to the gestational age, which is an accurate predictor of the correct insertion, and also it has the benefit that it should be known before the birth, and also this table should be placed next to the radiant warmer. As we say, it's to provide the endotracheal tube insertion depth as we see it at the border of the lips, according to the gestational age and to the baby's weight. How we know it is inserted in the right way, as she said, once it is inserted, we listen for the breath sounds at both the chest and near the axilla, and it should be equally at both sides. If it is audible over the stomach, you may be inserted incorrectly through the esophagus, or if may be unequal, you may proceed further into the mainstem bronchus, or you inserted wrongly. If we need to know if it is correctly positioned or not, it should be equal on both sides, as we say. If it is too far, it may be decreased on one side, and to adjust it, we lift it further, and the breath sound should, as we say, become equal. Mainly, it will go to the right mainstem bronchus, and you hear it louder on the right side. If it is not inserted equally on the left side, it will be quieter, and when you adjust it, it should become equal. How to secure the endotracheal tube and keep it in place? You need a tape. The tape, it should be cut as a pair of pants, and the uncut part, it would be in on the baby's cheek, as we see here, and the cut part, it will be on the upper border of the lip, and it will be wired along the endotracheal tube, and it will be fixed. How to ensure it is correctly placed? Absolutely, you should obtain a chest X-ray for final confirmation. As we see in those two pictures, what do you think? Which one is correctly inserted? A or B? Absolutely, it would be A. Why? Because the tip of the tube, as here, as is pointed by the arrow, it should be against the first or second vertebra and should be above the carina and not exceed it. As we say, avoid using the clavicles as landmarks because they are different according to the view of the chest X-ray and from a baby to another. And if the tube, as we said, advances too far, it may touch the carina or enter the main stem bronchus. It will cause the left lung to collapse, as the second picture. Second picture, horn. The second picture, the tip of the endotracheal tube, it exceeds the first and the second vertebra. It almost on the fourth, and this is too far. You insert the endotracheal tube. Left lung collapse. Yeah. Mm-hmm. Absolutely, we focus on the teamwork. There is an assistant. The assistant have important roles. You should not work solo. He would check the equipment, mainly the laryngoscope, and that the suction is set on the right number 80 to 100, and it should he prepare the tape and the securing device and attach the chest leads, pulse oximeter, and absolutely he will hold the equipment and monitors the heart rate, provide thyroid, cricoid pressure, and make sure that it is inserted at the same depth, and the breath sounds should be equal. After all of these, if the baby's condition has not improved after achieving chest movements, okay, and you do all ventilation corrective steps as we discussed in the previous lectures, Mr. Soba, who reminds us of Mr. Soba? Myself. Yeah. Yes. A, consider alternative airway. Excellent. If a baby's condition, as we said, not improved, what could be the problem? It could be thick secretions obscuring the endotracheal tube. How we suction it, either through the suction catheter, as we say, it's at 80 to 100, or through a tracheal aspirator. Although there are more common problems that the endotracheal tube must be that must be considered if the baby's condition worsens after the intubation. It is in the mnemonic DOP, displaced endotracheal tube, or obstructed endotracheal tube, or pneumothorax, or equipment failure. You should go through these and check it, and as we say, clinically by hearing equal breath sounds, and you confirm it by the chest X-ray. And as we say, focus on teamwork, call for additional help when needed, communicate effectively, and maintain professional behavior, and absolutely use the available resources. Some of the frequently asked questions: why should we insert an endotracheal tube before starting chest compressions? Because the most problems are respiratory, and we can provide effective ventilation and postpone the need for chest compressions. Endotracheal tube prior to starting chest compressions, as we say, to ensure maximum ventilation, and in many cases the baby's heart rate will rise during the 30 seconds of intubation, and the compressions will not be necessary. Also, you must have a provider with such good skilled intubation skills in the hospital. He cannot be in a distant location. He must be available at any time you need help. And should sedative and pre-medications be used before intubation? Absolutely, it is an emergency situation, not an elective process. It's not necessary to use sedative medications. A video laryngoscope, it be useful for neonatal intubation, absolutely. If you find a problem with getting the endotracheal tube in, you can use a video laryngoscope under direct vision. You insert it, identifying the anatomic landmarks, and absolutely it needs more expertise, and it makes it easier. We will proceed with this video as a quick recap for all the things we discussed in the previous lecture and this lecture.
Part 1 of this video demonstrates endotracheal intubation and the responsibilities of both the intubator and the assistant. Part 2 of this video demonstrates use of the tracheal aspirator, also called a meconium aspirator. The assistant has many tasks before, during, and after intubation. Assembling supplies should be done prior to the birth if intubation seems likely. Choose the correct size endotracheal tube. You may want to post this chart from the textbook or keep it with your airway supplies. These items should be within reach: stylet, endotracheal tube, laryngoscope blade, laryngoscope handle, tape or securing device, stethoscope, CO2 detector, and measuring tape. If the intubator will use a stylet, insert it but leave the tube in the package where it will stay clean. A stylet provides rigidity and curvature for placement. Ensure that the tip does not protrude beyond the end of the tube. Make sure the stylet can be removed easily. Use a size 1 Miller blade. If the light is dim or flickering, replace the batteries or bulb. Place the laryngoscope on the operator's left side. Occlude the suction tubing and set the suction between 80 to 100 millimeters mercury. Connect a 10 or 12 French suction catheter. Make sure the PPV device is present and functional. This team is using the T-piece resuscitator. The assistant makes sure the baby's head is in sniffing position and aligns the baby's body. The assistant monitors the heart rate and monitors oxygen saturation if pulse oximetry is working. The assistant also monitors the time and announces when the intubation attempt has exceeded 30 seconds. The assistant places the suction catheter into the operator's hand if requested and applies suction. The operator should never have to look away from anatomic landmarks. If requested, the assistant applies cricoid pressure by using the thumb and the first finger and pressing gently on the cricoid cartilage downward and toward the baby's right ear. When asked, the assistant hands the ET tube to the operator in insertion position. After insertion, the assistant removes the stylet and connects the CO2 detector, attaches the PPV device, and hands it off to the operator. The assistant listens for an increasing heart rate and bilateral breath sounds and notes symmetrical chest movement. The assistant reminds the operator to check the CO2 detector for a color change to yellow within 8 to 10 assisted breaths. Now let's demonstrate steps of the intubation procedure itself. Adjust the height of the warmer or bend down to improve your view of the airway. Use your right index finger to gently open the baby's mouth. Hold the laryngoscope in your left hand. Insert the laryngoscope blade into the right side and slide the blade over the tongue toward the midline. Gently push the tongue toward the left and advance the blade until the tip lies just beyond the base of the tongue in the vallecula. Lift the laryngoscope and blade to expose the pharyngeal area. Raise your arm, but do not bend or rotate your wrist. Your wrist should remain stable. When lifting the laryngoscope blade, do not pull the top of the handle or rock the blade, which may injure the baby's lips and gums. This clip shows the infant's airway during intubation using video laryngoscopy. The laryngoscope blade is at the top of the screen. Here, the operator is looking for landmarks. An OG tube is in the esophagus at the bottom of the screen. The vocal cords appear. The top of the blade is in the vallecula. Now the tip of the blade lifts the epiglottis, exposing the open vocal cords. The operator advances the ET tube through the vocal cords, past the single black guide mark to the double guide mark on the tube. Carefully remove the laryngoscope. Hold the tube securely. Your assistant will remove the stylet, attach a CO2 detector and PPV device, and transfer the PPV device to you. Having the same person hold the tube and the PPV device helps avoid accidental extubation. The assistant checks tube placement by listening for a rising heart rate and noting color change on the CO2 detector within 8 to 10 breaths. Other indicators include bilateral breath sounds in the axilla and symmetrical chest movement. The nasal tragus length is one method for determining correct insertion depth. This can be done before or after intubation. Measure the distance from the baby's nasal septum to the ear tragus and add 1 centimeter. This baby's nasal tragus length is 10 centimeters. Add 1 centimeter for an insertion depth of about 11 centimeters. The 11 centimeter mark on the tube should be at this baby's lip. Secure the tube. If using tape, tear it so that it looks like a pair of pants. Place the uncut section on the baby's cheek close to the corner of the mouth and the upper leg of the tape above the baby's lip. Wrap the lower leg of tape around the tube. Leave a small tab of tape folded over at the end to assist removal. To prevent accidental dislodgement of the tube, the person providing PPV should hold the PPV device and the tube. The ET tube is held against the hard palate with the index finger. The third finger rests against the chin, and your thumb may rest on the baby's head. Here is the intubation process shown in real time. Note the roles of the intubator and the assistant and how they work together as a team.
Okay, Clara, we're going to intubate this baby. Is the equipment ready?
Equipment's ready.
All right. Can I get some suction?
Suction.
Thank you. Okay, cricoid pressure, please.
Cricoid pressure.
Good. I see the cords. Get the endotracheal tube. All right. Looks like it's through the cords.
Removing your stylet.
Okay. Let's put on the CO2 detector.
CO2 detector's in.
All right, I'll take this. Can you listen for breath sounds?
Listening for breath sounds in the axilla. I hear breath sounds on the left. I hear breath sounds on the right axilla.
Okay, I see good chest rise, and I have mist in the tube, and I have color change.
I hear heart rate, and it's rising steadily. I hear good breath sounds on both the left and the right.
This section of the video demonstrates use of the tracheal aspirator, also called a meconium aspirator. This infant required PPV for persistent bradycardia and apnea. The team has performed all of the Mr. SOPA steps. The peak inspiratory pressure is at the recommended maximum of 40 centimeters water, but there is still no chest movement with ventilation. The team suspects that the airway is obstructed with thick secretions. This team decides to first suction the ET tube with a suction catheter, but there is still no chest movement with ventilation. They decide to suction with the tracheal aspirator. Connect a meconium aspirator to a suction source set at 80 to 100 millimeters mercury. Connect the aspirator directly to the ET tube connector or to the integrated suction port if your ET tube is equipped. Occlude the suction control port on the aspirator with your finger and gradually withdraw the ET tube over 3 to 5 seconds. Resume face mask PPV or quickly re-intubate. If chest movement is evident, ventilate for 30 seconds and reassess the heart rate. If chest movement is not evident despite Mr. SOPA steps, you must repeat tracheal suction until you have cleared the airway and achieved effective ventilation.